Welcome, welcome. I've been giving this talk about diabetes, I think, for about 15 years now here in Marco, and man, has it changed a lot, particularly in the last 5 years. We're going to try to cover a lot of ground over the next 30 minutes. Detailing the scope of the problem, talking about the adverse outcomes of hyperglycemia, which I think everyone's familiar with, outline some of the controversies about tight glucose control, evaluate some of our treatment options, and jump into the whole GLP-1 receptor agonist controversy in the perioperative setting. Diabetes is prevalent. About 10% or 11%, almost 12% of the nation has diabetes, 38.4 million people, and about 23% of the adults who have diabetes don't know they have diabetes. So that's diabetes. And then there's prediabetes, with about over 1/3 of the country with prediabetes, and about half of the folks who are greater than 65 have prediabetes. Very, very prevalent. How do we diagnose diabetes? I think most of us remember these numbers: a hemoglobin A1C greater than or equal to 6.5%. A glucose, a fasting glucose, meaning you have fasted for 8 hours, no caloric intake for 8 hours, with a fasting glucose of 126 or higher. We're not going to talk about glucose tolerance tests. The final one is typical hyperglycemia symptoms, plus having a random glucose of equal to or greater than 200. And remember, a few caveats: you got to be fasting for 8 hours before you're fasting glucose. And then you can have some misleading hemoglobin A1Cs. The hemoglobin A1C relies on the fact that red blood cells typically stay around for around 90 days, which is why we check our A1Cs every 3 months. But if your red cells are turning over more quickly because you have a hemoglobinopathy, G6PD, HIV, hemodialysis, you got a recent blood transfusion, that throws it all off. And so you can have a misleadingly low hemoglobin A1C when you really do have diabetes. And just remember that if your hemoglobin A1C is elevated or your fasting glucose is elevated and you don't have any symptoms, you probably should have it checked twice before you decide that the patient has diabetes. The ADA comes out with new recommendations every year about caring for patients with diabetes, but this one has not changed for a long time. Basically, if you have a patient who has hyperglycemia or known diabetes coming into the hospital and you don't have an A1C on them in the last 3 months, or have access to an A1C that has been done in the last 3 months, get the A1C so you get a sense of where they are with their diabetes. I am not going to belabor this. We all know that having hyperglycemia in the hospital causes problems. So this was a study from a long time ago from one of our famous endocrinologists at Johns Hopkins, Sharita Golden, who was able to show that if you have diabetes, you have a much higher likelihood of having an infection while you are in the hospital. And the higher your glucose goes, the more likely you are to have that infection postoperatively. Same is true for mortality. The higher your glucose goes in the hospital, the higher your mortality goes in the hospital. And this was from an ICU study in 2003. These things have been repeated over and over again. Being hyperglycemic, having diabetes in the hospital is not good for you. The question then is, what do you do about it? Do you try to get them to have a normal glucose during their hospitalization, or do we allow for a little bit of hyperglycemia? So this was one of the landmark studies back in 2001 that made us think, oh, maybe we should be trying to get really tight control. The study was done with ICU post-op patients, surgical patients, where they wanted to try to get a tight glucose control of 80 to 110 versus a not so tight glucose control of 180 to 200. And they were able to do it. And when they did it, they saw that that intensive control, 80 to 110, actually seemed to improve outcomes, with the most important outcome in mind, which was in-hospital survival. And so you could see the intensive glucose control really made a difference. What we began to see, though, was those patients who had intensive glucose control also had a lot more hypoglycemia and severe hypoglycemia. You can see 39 patients in the intensive arm versus 6 patients in the conventional arm. Lots of people tried to repeat this study, and folks had a really hard time getting the same results. And sort of over and over and over again, we were not seeing that intensive glucose control was actually getting this beneficial outcome. And this sort of came to a head in 2009 in the NICE sugar study that came out in the New England Journal of Medicine, where they again looked at 6,000 ICU patients. About 2/3 of them were post-op patients, about another third of them were medicine patients, and these were sick patients. 93% of them were ventilated. And again, they were looking at, are you alive at 90 days as the primary outcome? Tight control, essentially that same thing, 80 to 110. Not so tight control, 144 to 180. And what they saw here was at 28 days, they started to get a signal, although not statistically significant, that patients who had intensive glucose control did worse in terms of mortality. And at 90 days, it now was statistically significant that you died more often if you were getting intense glucose control. And what was very clear was those patients who were getting the intensive glucose control, they had a lot more severe hypoglycemia. So this generally seems to be the consensus of where we are now, that you don't want to have glucose control that is too tight. And this included all of the different subgroups that they looked at: patients with known diabetes, sepsis, trauma, operative admissions, as they tried to analyze the data. And there have been lots of Cochrane databases where they've gone through systematic reviews to see if there was a signal that intense glucose control actually might help, and there is no signal. All-cause mortality is not improved by having intense glucose control, and severe hypoglycemia is increased with intense glucose control. So the preponderance of the evidence is that intense glucose control is not beneficial to patients. So then how tight is too tight? And for SpongeBob here, those pants are certainly too tight. So we don't want to be too tight. And too tight is having a glucose of less than 108, of trying to get that patient between 80 to 110. In general, that is too tight. There may be some subgroups that we are still trying to really figure out, but in general, being below 108 is too tight. So what should we be aiming at? So the ADA says for your critically ill patient in the ICU, 140 to 180, and that you should be using an insulin drip to get there. Your non-critically ill patient, 100 to 180. And then there may be selected patients, particularly CABG patients, cardiac surgery patients, that maybe you're trying to get 110 to 140. And then in general, the ADA says your perioperative period, you should be around 100 to 180. The ACP is a little bit more loose. The ACP just says 140 to 200 for your critically ill patients, and they don't really give us a number for the non-critically ill patients. But we are not trying to make it too tight. So how do we reach the glycemic goals? The answer is not by using sliding scale alone, usually. And one of the recommendations from the ADA guidelines is get help. If you have a group that you can consult in the hospital that's specialized in diabetes or glucose management, get their help and make sure that they are involved in your patient care. But in general, what we are trying to do is mimic what the pancreas does. And what the pancreas does is all day has a basal amount of insulin coming out, and just as we ate, your insulin shot up, and then it's going to go down rapidly as you digest your food. And so what we try to do when we give exogenous insulin is to mimic what is going on with the pancreas. Here are some of the different types of longer-acting insulin. There are even longer-acting insulins out now, insulins that last a week or 2 weeks. It's pretty crazy. We don't have a lot of data on those really long-acting insulins and perioperative medicine. But here are many of the insulins that we use on a regular basis, things like glargine and Detamir, that don't have much of a peak to them, but are basal amounts all day long. NPH still has a peak, so if you are using NPH, remember that it peaks more than some of our other long-acting insulins. And here are the short-acting ones. And you can see things like Lispro and Aspart, where they have a peak that is very rapid in the first couple hours after you give it, as compared to something like regular insulin that has a much lower peak and lasts much longer in the bloodstream. So what are some of our definitions of how to give insulin to patients? Often what we are trying to do is a basal, prandial, plus bolus correctional regimen. The basal is your long-acting insulin. That's your glargine or your Dedimer. Your prandial, what you're going to give either right before they eat or right after they've eaten. Some people choose to give it right after they've eaten because you know how much they've eaten and you know that you are not going to make them hypoglycemic if you give them a full dose. That is your short-acting insulin, things like Aspart and Lispro. And then your bolus correctional, which is all in the same schema there of this regimen, also your Aspart or Lispro. If you do bolus correctional on its own, that's sliding scale. If you do bolus correctional with basal and prandial, that's okay. That's just correctional. Do we know that correctional actually makes a difference? No, we don't know that correctional really actually makes a very good difference. The most important part is having basal on board, and if they're eating, having the prandial, but everyone's going to do a correctional as well. And here's one other regimen where you can do the basal plus your bolus correctional. Again, basal being the glargine or Dedimer, bolus correctional being things like Lispro and Aspart. And then the sliding scale by itself, which almost should never be used. When you are taking care of patients in the hospital who are non-critically ill, we will probably not be using an insulin drip. You're probably going to be giving them sub-Q versions of insulin. If your patient does not have good oral intake, you are not giving them their prandial insulin, the short-acting insulin for having meals. You're just going to do basal and the correctional. If they have good nutritional intake, then you're going to do all three. You're going to do the basal, the prandial, and the correctional. So how do you figure out a dose? Well, you can ask the consult service, but you can also have two methods of determining a total daily dose, the TDD. One method is, are they on insulin at home? If they're on insulin at home, just add up the amount of insulin they're taking at home. How much glargine, how much Aspart, whatever they're taking, add it all up. And that will give you your total daily dose. And often the way we will use that total daily dose is to either give them exactly what they do at home or take 50% of the total daily dose and make it basal, and take 50% and make it the nutritional that you're going to give over 3 times or however many meals they're having in the day. Now, you do need to adjust for what their A1C is and whether you really believe that they're taking this insulin at home, and you will find many patients who are giving really high doses of insulin because they're not actually taking the insulin at home. And so every time they come back to see their primary care doctor, their A1C is 10, and the primary care doctor says, well, I must need to give you more insulin. And the answer is they're actually not taking their insulin. So you have to be able to tease some of that out. The other method, which then you don't have to tease out how much insulin they're really taking at home, is to do weight-based. And weight-based, you often use these 3 units per kilogram per day that are based on the patient's insulin sensitivity. If you think a patient has never seen insulin before and might be very sensitive to it, then you use 0.3 units per kilo per day to decide what their total daily dose is. If you think that they may be insulin resistant, then you use the 0.5 units per kilo per day. And again, when you come up with that number of what their total daily dose is, you then split it 50-50 between their basal and what you're going to give them in nutritional over the 3 times during the day. We're going to practice this later on in a session at 11 o'clock. If you have a patient who is older or whose renal function is not nearly as good as you would like it to be, you're going to decrease their total daily dose. Insulin is secreted by the kidneys. If your kidneys aren't working, you're going to have more insulin build up. so you want to give them less insulin overall. So if you think someone's creatinine is elevated or they're older, you're going to use the 0.3 units per kilo per day rather than 0.5. And again, sole use of a sliding scale is discouraged by the ADA. Well, how do we monitor their glucose during all of this time? Well, if they're eating, you just check their glucoses before meals. Easy. If they're not eating, you're checking every 4 to 6 hours. If they're on IV insulin, you probably have a protocol for this in your hospital, but you're doing it every 30 minutes to 2 hours. You may have some glucose commander machine that is telling you what to do, but you'll have something that you are checking pretty frequently. And then for your patients who come in now, the CGMs are becoming more ubiquitous. Everyone's wearing one these days. What do you do with patients who are using their CGM? Well, the ADA says you can still let them use their CGM. You don't have to stop it when they come in the hospital. But if you're going to make decisions about how much insulin they're getting, you should probably do a point of care glucose to check. Don't just rely on their CGM. But in general, they can follow along on their CGM. You don't need to disconnect it. You're also not allowed at this point to start a CGM in the hospital to be able to follow their glucose. I think we're going to get there in the next couple of years, but not yet. So we can't start a CGM to be able to follow glucose in the hospital. And if they already have a way, they have an insulin pump, automated insulin delivery system, you should have an institutional policy over whether you use their pumps or not. There are plenty of places that let folks use their pumps when they are in the hospital and their CGM. Again, if you're using their CGM, you should probably use point of care to make decisions about what you're going to do with their insulin. Is there a pre-op A1C that is too high to do surgery? Well, the ADA says we'd like it below 8%. And when I gave these talks before, I would show a slide that showed that you could get a number of your patients into an area below 8% if you worked with them before surgery. But sometimes it would take about a year to do so, and you would have to decide, is waiting a year worth it for that patient who might need to have that hip repaired or knee replaced or whatever it should be? Well, now we can get A1Cs down a lot faster. And for those of you who have used the GLP-1s and the SGLT2 inhibitors, you have seen monumental shifts in patients' A1Cs over very short periods of time. It is a miracle. For patients who I never thought would be able to get an A1C down at 6% without being started on insulin, you now see them getting down to 6%, 5.5%, and they're not hypoglycemic. It is incredible. So I think we probably can be a little bit more stringent about trying to get patients' A1Cs down below 8% if we are using these new medications to get them there. But again, keep in mind how much the waiting is going to affect the patient. Okay. And now we enter the world of the other medications, the incretin therapy, now our GLP-1s and our GIP receptor agonists. And these things have been amazing. They decrease appetite. They decrease food intake. They cause weight loss. They have your A1C go down. They do cause some side effects like nausea and diarrhea and abdominal pain. But if you slowly increase their GLP-1 regimen over time, patients tend to be able to deal with it better. It also decreases your gastric emptying, which is what you all care about in the perioperative world. And so we're going to get into a little bit of that. Now, it may be the GLP-1s cure everything. And every day you hear about a new thing that comes along that GLP-1s may be improving. Lower risks for patients with alcohol use disorder to have rehospitalizations, slower progression to cirrhosis, moderate knee osteoarthritis pain may be improved, moderate to severe obstructive sleep apnea. There's actually an FDA indication for that now. We can prevent some asthma exacerbations, apparently. We may have obviously cardiovascular benefits, Alzheimer's benefits, and obviously benefits for your A1C. These have been wonder drugs. We will find out over time if there's other stuff that we don't know about them, bad things that it's doing, but right now they look amazing. But this decreased gastric emptying has everybody worried, and lots of case reports of folks who have aspiration because of the decreased gastric emptying. In January, we had published, that came out basically in October, this multi-society clinical practice guideline on pre-op GLP-1 therapy. So what did they say? They said you want to evaluate your patients for risk factors for having reduced gastric emptying. Their risk factors that they looked at are, is the patient in the escalation phase? So did they just start this weekly GLP-1 and you are going up on the dose every few months or every few weeks to get them to the highest dose that they can get to? That is supposed to be a period that puts you at higher risk. Are they on the highest dose? That is supposed to be something that puts you at a higher risk. Are they on the weekly dosing instead of the daily dosing? It seems like daily dosing is much less risky, that the weekly dosing is worse. Do they have symptoms? That's probably the most important thing. Do they have vomiting? Do they have nausea? Do they have dyspepsia? Things that make you think that they are having retained gastric products. And then finally, are there other medical conditions that may also delay gastric emptying? They wanted to try to come up with a scoring system when they were putting this together. They couldn't come up with a scoring system because there's just not enough data. So there's no scoring system for this right now to say, oh, you are definitely high risk or you are definitely low risk. You just have all those risk factors that I showed you. Now, for those who don't have an elevated risk, they don't have any of those descriptions that I had on the last slide, you would say that those patients are not high risk and they should be fine to continue their GLP-1 without stopping it going into surgery. For patients with elevated risk, you need to do a couple things. One is consider the risk of withholding that GLP-1. If through shared decision-making you decide to stop it, well then if they're on daily, you stop it the night before. If they're on weekly, you stop it the week before. But no one knows what the right amount of time is to actually withhold the GLP-1s. And this day before and this week before may not be nearly enough. You should assess all patients for symptoms on the day of surgery. If they have symptoms, the guideline says, or the guidance says, you might want to do POCUS and see if they look like they have any retained gastric contents. If they do, then you want to think about rapid sequence intubation. If they don't, you're good to go, just do your surgery. So do patients have retained gastric contents? This is a study that ended up showing of 124 patients. If you were looking at patients who were on weekly GLP-1s compared to patients who were not on weekly GLP-1s, those who were on weekly GLP-1s definitely had more retained gastric contents on the order of more than 1.5 cc's per kilo for that patient. So there was clearly an association with being on the GLP-1 and having retained gastric contents at about threefold higher. So this was about 56% to 19%, right? Significantly higher. They did not find that there was a statistically significant association, although you can see downtrending for how many days it's been since you last took your medication and whether you had the likelihood of having retained gastric content. So it gets better over time, but it was not statistically significant. And certainly within this sort of 7-day period of time, you're not going to say, oh, look, everything's fine, right? Still a high percentage of patients who were 7 days out ended up having retained gastric contents. There are other studies, and there's still not a ton in this area. This was a study of EGD colo patients who they ended up finding and looking through all these different health records of about 114 million de-identified health records, doing these observational studies, were able to show that there was an increased aspiration pneumonia risk for these patients. But other studies have not shown that. So this was a study of GLP-1s before EGD that didn't show any increased aspiration risk. This was another study of GLP-1s before EGD and colo that didn't show any increased aspiration risk. So there have been studies out there that show maybe the risk that we're worrying about is not quite as bad as we think it is. We do have this study that I think is really appropriate for us to look at that looked at patients who were on GLP-1s who had emergency surgery. So clearly emergency surgery, you're not holding your GLP-1. You didn't know you were going to have surgery. And so they evaluated the patients who had emergency surgery on their GLP-1 versus not having a GLP-1. And in this study where 15% of the patients were on the GLP-1, there were no increased respiratory complications in those patients. So these were patients clearly not holding the GLP-1, going for emergency surgery, who did not have any repercussions from this. This systematic review and meta-analysis wanted to see, well, what actually happens in gastric emptying when you are on a GLP-1? And what they showed in this meta-analysis was that solids slowed down. They had about a 36-minute delay. Liquids did not. There was no delay. Liquids seemed to be okay from this systematic review and meta-analysis. And so what many people are coming to at this point is we probably should be continuing the GLP-1s. And we may find out that stopping GLP-1s is like withholding a beta blocker or a statin, that actually is deleterious for the patient. And so we probably should be continuing the GLP-1, but having them do a liquid diet for 24 hours before they have their procedure. And then doing the fasting for whatever you guys have them do for that particular procedure, the standard pre-anesthesia fasting period. This is probably where we are. Last year, what I said was hold the medications. Now, where we are is probably continue them unless you are at really high risk and you have a discussion about it, and have them do the liquid diet. SGLT2 inhibitors, again, this also may be something that we find out we should not be withdrawing from patients before surgery, but right now what we tell people is we should stop them 3 days before or 4 days before, depending on which SGLT2 inhibitor you are on. For those of us who are internists, we are using SGLT2s in the hospital on a pretty regular basis now for our patients with heart failure and CKD. So stopping these before surgery, although we are worried about euglycemic DKA, we may find out that we don't actually need to be doing this. And it actually may be appropriate to be continuing some of our other home medications like metformin in the hospital, although that has not changed yet. We'll go through some of that very shortly. So what are the pre-op instructions? Stop your SGLT2 inhibitor 3 to 4 days before surgery. Patients on your GLP-1 should be on a liquid diet 24 hours in advance of surgery. Withhold the metformin on the morning of surgery. Withhold any other oral hypoglycemic medications, especially sulfonylureas. If they're on NPH, give 50% of the NPH, not 100%. If they're on glargine or Dedamer, give 80% of that. Do not give any short-acting insulin if they're not eating, and manage all high-risk patients who are taking GLP-1 agonists as if they have an increased risk of having retained gastric contents. Monitor those glucoses as we talked about. And again, we don't have any data on the ultra long-acting insulins, the ones that are lasting for a week or a month. The new AHA guidelines say that you can actually think about continuing metformin. That is not in the ADA guidelines yet, but that is in the new 2024 AHA preoperative guidelines. This is just a nice reference to remind ourselves to hold most of the oral medications, give 80% of glargine or Dedamer, give 50% of NPH on the day of surgery. And we do that because if you don't give any insulin on the day of surgery, they will be hyperglycemic. And it looks like if you give 100% of the insulin, the long-acting, they have a good chance of becoming hypoglycemic. So how do I discharge them? If their A1C is above 7.5, talk with their PCP or get a consult to find out how to better optimize their diabetes care. If their A1C is below 7.5, you're good to go. So the pearls are, don't use the sliding scale alone. Your oral agents are held, although I may be saying something different a year from now. Think about doing the 24-hour liquid diet for patients on the GLP-1, and patients previously receiving insulin should be on a basal regimen. There is strong evidence that glucose control impacts outcomes, and try that basal prandial plus bolus correctional for your patient who is in the hospital and usually on insulin at home.